Okay, so I guess you can see the topic. I understand that it was advertised to you guys as well, what I'll be speaking about. I guess where this comes from, and I expect this talk to go for about 50 minutes, okay? So I guess just sort of so you're sort of aware of the timing. There's a fair bit in it as well. And I guess when we're sort of thinking about what this is and the ProSight, my role being a diagnostic educator is about allowing you guys to, I guess, effectively use your pathology, okay? So you guys have already got this equipment, and I guess my question mark is when I get this right, is you've got the ProSight that's almost like what we could sort of use as the analogy of the F18, okay? So it can do lots of stuff, but sometimes we sort of treat it like a little Cessna. And so I guess what I'm hoping in my session today is to work with you guys to sort of go, okay, let's use the ProSight to its full potential so it can actually do things that the F18 does. So the things that I'll be going through is why do a CBC, when we should be doing it, components of it, the ProSight, the technology, those dot plots, and then working through about the blood smears and so forth. Now, I'm only going to put a small amount into the last sections because the major section will be in the middle. So when we're thinking about the CBC or the complete blood count, sometimes we drop it off, okay? And the reasons why I think veterinarians, and I'm talking veterinarians because they're the ones that usually make these decisions, drop it off is because it rarely gives a diagnosis. But just because it doesn't give a diagnosis, it's important that we consider what it can do. And it's actually helping us in our search of what's happening behind the scenes. And it's giving a general health status of what's happening. So it's like the flashlight, like it's black, there's the flashlight, and it's saying, look in this direction. Other tests are going to find the needle in the haystack. But this one is the flashlight to say, look over here. So if we think about it from that angle, then we're going to find out that it's actually going to give us a lot of information. So a general health indicator of disease, and I've put in big letters, capitals, that it's objective data. So it's not subjective. So it's not about your clinical science. It's about numbers and it's about objective data to actually show what's going on. And it is the most sensitive test because things change quickly with a CBC. And because things change quickly, we can then characterise the severity of disease by looking at a CBC. So I'll be just going through a couple of examples of that as I walk through. I've got this. Okay, so thinking about the CBC being a sensitive detection of occult disease. So disease that's going on, but the patient on the outside is not showing that. So what we can see with the erythrograms, so the red blood cells, we can see changes that are going on with anemia, with morphology changes, and they could be due to metabolic, endocrine, inflammatory changes. We can see changes in the leukogram that could be due to inflammation, could be due to stress, or it could be due to other things as well. The other thing to I've underlined here is the stress leukogram cannot be hidden. And how many times do we find that clients will sort of say that the pet is just not doing well, and it's just this vague not doing well, okay? And then they come in and the pet is happy and excited and jumping around, physical examination is done, everything is normal. But CBC could show things that's going on underneath. Also with the platelets. So we can see that there could be changes with the platelets and changes even with inflammation due to the platelet changes. Okay, so if we're thinking about the white blood cells, this is sort of a table that we were shown at university, okay? So it's that kind of level. But to think about when with white blood cells, the first thing we want to do is we want to categorise. Are we looking at inflammation? Are we looking at stress? Or are we looking at excitement? So, and I just want to sort of emphasise the difference between those two. So excitement is an epinephrine release. So that is that the animal is excited from the drive-in, from the procedure of what's happening, from what's happening. So we can have changes that occur in minutes with those guys. It's not the stress leukogram. The stress leukogram is because of changes because of glucocorticoid changes. So that takes about 4 to 6 hours for those things to change. So that could be showing that there's something underlying there with that stress. And as you can see here, if we look at the difference between that, it's really important to tell the difference between stress leukogram and inflammatory leukogram due to these band neutrophils. And I'll explain what they are a little bit later if you're not sure. Okay, so I talked about trending the CBC is important because it gives us objective data and it can't hide the illness and it can't mask improvement. I've got this thing. This is an example of a dog that had an abscess in its prostate. What we've got here is tracking the hematocrit across the days. The animal presented on this day, and we had surgery on day 4. And we can see the hematocrit decreasing over time. So blood was taken every second day. And then we see after surgery how the hematocrit improves. So this is a prostatic abscess. But that's when we saw clinical improvement. So just even looking at the hematocrit, we're seeing improvements in that before we actually observe that there's improvements clinically, looking at this example. Looking at the same example, this is just looking at general leukocyte numbers. What we're seeing is an increase in numbers going into surgery. Surgery occurs, then we see a decrease in numbers, and here's when we see clinical improvement at day 13. Breaking up those leukocyte numbers now into the lymphocytes, tracking here, the monocytes tracking here, and the eosinophils, okay? And we can see just looking at the lymphocytes and monocytes here, the changes that are occurring. And we can see the improvement in the clinical situation of this pet before we actually see the physical, clinical, outside, subjective changes. So that's just monitoring a CBC every second day with this particular case. Has anyone heard of VetConnect Plus or used it? Great, okay. So that's a tool, that's a website, that's a free service provided by IDEXX, and that is one way you can track your data. So what we've got here is this is using the example of creatinine, okay, but it's just using the example. That creatinine on one day is this, but if we track it and seeing the graphs, we can see the changes over time. And in this particular example, even though this is in the normal range, for this particular patient, gee, that's an elevation, as we can see the tracking. So looking at previous data and comparing is really important, and that's a tool that can do that for you. Okay. So when should we be considering doing haematology? Well, with our sick patients or our ain't doing right kind of patients, and also with our healthy patients as well, because we're looking at that tracking and we're looking at anything that could be underlying there. And that could be for your pre-surgical screenings or any other kind of screenings. And I know what you guys do here would be different to general practice, but looking at those kind of screenings. Okay, so in your training, you would have been taught 3 parts in a CBC. Red blood cells, white blood cells, and platelets. When it comes to the ProCyte, I want you to be thinking of it as 3 parts, being the data, the dots, and the cells. Okay, so the data being the numbers you get. Then with the ProCyte, there's those dots, and usually a lot of people don't understand what they do, so let's just ignore them. But the dots actually then help us to figure out the cells, and that's where our blood smears come in. And I know there's a lot of practices go, blood smears, and they're a bit concerned about how to do that. But when we're looking at a complete CBC, what we're looking at is those 3 components. A lot of people just focus in on that. And I guess the journey is that we really need to be using the dots to go, is that data right? And it's because we're using an analyzer. And even though the analyzer, the ProCyte analyzer is actually, the technology of it is the same of what the technology is in the reference lab. But you can actually get a better quality sample because you're using a fresh sample with it. So that would be the difference instead of transport. And it's an analyzer, it's a robot, okay? So when I use the word robot, it's programmed. So it's programmed that a particular cell should look like this and should do this, and therefore it graphs at that. But when we have abnormal cells, that's when the analyzer gets challenged. And that's where we look at dot plots to go, okay, what do we do when it's getting challenged? And you might find next to a lot of the analytes, you'll see little asterisks appear. Does anyone recall when they see little asterisks? Yeah, cool. Okay, so the asterisks basically are saying, I need human help. Okay, it's not that I've stuffed up, it's I have done the best I can, but I'm getting a bit challenged. I need some humans to help me here. And I'll be walking through that as well. Okay, so I guess just sort of looking a little bit about the technology of the ProCyte. Things have changed a lot in the in-house diagnostic equipment area. I mean, when I was at uni 20 odd years ago, we had to do these manual counts, okay? And you know, you do this 100 cell diff, and is it right or is it wrong? You know, is it on the line in or is it on the line out, okay? And you can get variability with that. And then this here was revolutionary to have something like this. But if anyone recognises this, it's great for a PCV, but that's about it. Times have changed, and as you can see, times have changed. Then we stepped up to something that is an impedance technology that can only count cell size. So if you had 2 platelets stuck together, it could count it as a red blood cell. If you had 2 red blood cells stuck together, it could count it as a lymphocyte or a monocyte or something like that. So when it's counting cell size, that's when limitations come in as well. So if everything's normal, fantastic. But that's not always the case. Then when we had the LaserCyte come in, and the LaserCyte uses a flow cytometry technology. So it's the laser that shines at the cell, and then it's looking for scatter of light. And through that scatter of light, it can work out size, and it can work out granularity in the cell as well. Then the ProCytes come along, and it actually includes this technology, but it actually does a laminar flow technology. Actually, it's got it on the next one. There we go. So it's a laminar flow, laminar being single. So it's actually designed itself that it can just do a single row of cells, and it counts them on the size of that. It also has the laser flow cytometry in it, and it also has the fluorescence. The fluorescence, you might notice that you put some dye in there. The dye is for this fluorescence, okay? And this fluorescence picks up RNA. Does anyone know what I'm talking about when I'm talking about RNA? Yeah, I've got a nod. Okay, yep, no? Okay, do you want to share what it is? Just in simple terms.
It's part of the ribonucleic.
Oh yeah, that's the technical word. Yeah, absolutely. Okay, so it's part of the coding. Is that what you're trying to say? Yep, cool. And it makes protein. So the coding is to make protein. So if cells need to make protein, they need to do stuff, okay? So the more RNA in them, there's more need for that cell to do stuff, okay? So that helps decide where the cells go, okay, and the positioning of them as well. So it has these 3 technologies together in there, and combining that is allowing the precision to work out which cells are which through this. There's peer-reviewed papers that basically saying unparalleled accuracy and correlation as well. And what I've got for you as well is the brochure regarding the ProCyte, and also looking at the correlations between that as well, if you want that to take home or read later. Okay, so looking at some of these numbers when we walk through. So a lot of the times when we look at these numbers, we go, it's normal, abnormal, high or low, okay? And that's pretty much, that's our scan. And I think when we're looking at the CBC, what we need to be looking at is the relationships to each other. Because if we just go normal, abnormal, we're going to miss stuff. So looking at the red blood cell mass, it's really important that we see that those ones are in alignment. If they're not in alignment, there's something wrong. So is the analyzer having issues, or is there something wrong from a pathology perspective as well? So we need to be looking at that. These things you're probably aware of, but RDW is a new one. Anyone know what that could be? Okay, I'll answer. Okay, so that is the red cell distribution width. Okay, so it means that if we've got some little cells and some normal cells, there's the greater that's going to be. Greater that red cell distribution width will be. If we've got big cells and normal cells, the greater the distribution will be. So it's a measure of anisotrosis, or variation in size of cells. Okay, so that's what that one is. Then what we've got coming down, then we've got the reticulocytes as well, and I'll talk about the retics in a moment, okay? Then we've got the percentages of the white blood cells. Now we don't give reference ranges because it counts it. It counts 60,000 red blood cells in 2 minutes, and it counts 15,000 white blood cells in that 2 minutes. So it counts a fair number so we can get some accurate data here. So we've got the white blood cell distribution, we've got the platelets. Now usually most reports just give you platelet numbers, but what this has actually added onto it is platelet indices. So MPV is the volume of platelets, so it's a bit like the MCV. Then also the PDW is just like the RDW, so it's the distribution width of platelets. And then the PCT is like the hematocrit for platelets. So that's extra numbers to sort of explain our numbers of platelets, and I'll explain a little bit more of what those numbers can do as well. Okay, so the dot plots. So you may have noticed that there's these dot plots, and there's lots of dots, and there's 2 of them. Okay, so the 2 of them, this one here is the red blood cell dot plot, and this one here is the white blood cell dot plot. Each of those dots represents a cell. So when it is doing its analysis and looking at counting those cells, what it's actually doing, according to the algorithms that are programmed in here, is that if it's got so much fluorescence or it's so much size, it'll plot it in a certain spot. So that's how these are formed. And then on top of that, the coding will say, because you're a dot that lives here, I'm going to call you a red blood cell. Or because you're a dot that lives here, I'm going to call you a monocyte. Question mark is it? Okay, so that's where I'm going to use some examples to go, okay, is it or not? So, to actually interpret the numbers, we need to review the dot plots. And some of the, I guess, higher ups in IDEXX would actually prefer the reports to be presented with the dot plots up the top and the numbers down the bottom. So you actually look at the dot plots first, and then you look at the numbers. So in saying that, once you sort of get proficient about looking at the dot plots, you'll be able to read them within, I was going to say 10 seconds, maybe 20 seconds, okay, maybe a minute, but a very short time. So really with reading dot plots, it's about knowing the normal. Is anyone, when you went on long car trips and your parents gave you these sort of activity books and you had to spot the difference and spot the 5 differences? That's what dot plots are. Okay, so you guys would have done that. I know I did it when I was in primary school. That's all it is, okay? So you want your normal. Here's your normal, okay? So here's some examples, okay? I'll pass it to you. So there's some examples of normal and abnormal. What I've also got here is normals for different species, okay? Cows, equine, ferrets, unless you see them or not, but there they are, okay? So those are things that you can actually have near the analyzer or wherever you feel that that's safe to keep them. Okay, so looking at the dot plots. This is the red blood cell dot plot, and this is our normal. So what we have along the y-axis is the size. So the greater the size of the cell, the higher it up is on the y-axis. Then what we've got along the x-axis is RNA. Now platelets and red blood cells are end-stage cells. They don't have to do much. They've already been programmed to just do, okay? So that's why we see them up against the y-axis, okay? So they don't have much RNA. As I said, that's the things that create stuff. So then the changes that we usually see just in a red blood cell dot plot is the addition of reticulocytes. Now reticulocytes are, and I added this one in here, is like the teenager red blood cell, okay? And teenagers have pimples, okay? So that's how I sort of remember, is though they then have, and if they get stained up a special way, and that's what the fluorescence does, it picks up the RNA in there, okay? So your reticulocytes are going to pick up the RNA, and reticulocytes are the precursor to red blood cells. So why would we have precursor red blood cells? Because there's an increased demand for red blood cells. So more of them are being released from the various sources they come from. Okay, and then what it does a run through of the red blood cells, it lyses the red blood cells, and then it counts the white blood cells. Okay, so here's the white blood cell dot plot. So what we've got here on the x-axis is granularity. Okay, so the more granules that is in the cell, the greater it will be on this side. The more RNA that's in the cell, we're going to see them further up as well. So according to the granularity or the side scatter from that laser flow cytometry and the RNA, it depends on the positioning of where that cell will be. So this is a normal white blood cell dot plot. So what we see here is our neutrophils normally live here. This is actually canine because eosinophils in cats will live in a certain other position, okay? The basophils, your lymphocytes live here and your monocytes live here. Now it makes sense that these guys are lower down on the y-axis and these guys, as in our lymphocytes and monocytes, are further up because they've still got to do more. Lymphocytes have got to make antibodies. Monocytes have then got to turn into Pac-Mans and go into the tissue and become macrophages. So they've got to do more. So that's why they've got more RNA in them. Now there's one thing that's not coded there. Notice the orange colour, and I haven't given it a code there. Okay, that there is what's called, and you'll see the code in there, called the URBCs, or unlysed red blood cells. So what it is once it's done that red blood cell run, they didn't get lysed, and then we're seeing them here. And if we see an increase in those guys, they could be platelet clumps, or they could be weird red blood cells indicating there could be a bone marrow problem. So when we see changes there, but that's normally, we'd usually see a couple, and that's what we're seeing there. Okay, so our dot plots can help us by looking at them, and this is just a summary for me to sort of say what we will notice is that there is going to be a decrease in cells or an increase in cells. We'll notice that there's reticulocytes, or we'll also notice that there's platelet clumping as well. So that's where our dot plots can show that without even having to look at the numbers. Also we can see in our dot plots is changes in the red blood cells. So we can, oh wait a second, that one. We can see that the red blood cells are smaller or bigger, okay? We can see changes in the white blood cells, and we can pick up that there is immature cells, so that those band neutrophils I was talking about. We can see that there's changes in the white blood cells, and we can see the changes in the platelets as well. And I'll walk through some examples with some case studies now. Okay, so this one here, I'm not going to show you the numbers until secondary. I'm going to show you the dot plots first. So you'll sort of go, oh, you know, I can look at the dot plots and it gives me a bit of a guide. Here's our normal, and here's Onyx, okay? What's the major difference you see between the two? More scatter of?
On the left-hand side of the...
Yep, this stuff. So the pink stuff, okay? So that there is reticulocytes, and we're seeing them bleeding off the red blood cells. And that scatter being the fluorescence, because it's got RNA in them, so that is the reticulocytes as well. Absolutely, that's your major difference there, okay? The other thing just to point out is notice how each of these populations show normal clusters, okay, and separate clusters. But what we're seeing with Onyx is notice the red blood cells are starting to bleed down, and it's touching down into the platelets. So that's a bit of a hint to go, gee, we've got little red blood cells there. We've probably got red blood cell fragments that's happening there as well, okay? So that's one of the changes that we can also see. So here's the numbers, and what we can see the numbers and putting the picture together of the dot plots is we can see, now it's a bit hard to see lower red blood cells because there's so many of them and they're piled on top of each other, okay, because we've got a 2D picture, so it is hard to see that unless it's really, really severe, and then you start to see that, okay. But what we're seeing is that there is anisotrosis because of that suggested red blood cell fragments that's occurring, and also we've got reticulocytes as well, so those reticulocytes. And the RDW, I was mentioning about that red blood cell distribution, because we're seeing that we've got that anisotrosis going on with the reaching down here, and sometimes your reticulocytes have an increase in size as well. And then if a blood smear is made, you can see that there's lots of reticulocytes in that smear to confirm. Okay, this example. So this is Sable, okay? And as we walk through this one, and I think you already noticed that dot plot, there is reticulocytes there, okay? But if we look at the numbers in this one, we can see that the red blood cells are actually, it's not showing anemia in this case. And there's no changes in the mass in this case. We're not seeing changes in the morphology of the red blood cells in this case. And we're not seeing a change in the RDW. But we're seeing reticulocytes. Now that goes against what I was taught at uni, okay? What we were taught is that you notice that there's anemia first, and then you need to go and find out if it's regenerative or non-regenerative. And you do that by looking at reticulocytes. But now we've got an analyzer that can look at reticulocytes at the same time or in the primary run with the red blood cells. And that's actually showing results like this. And you go, this is interesting. And do we ignore it? Do we not? Look at a blood smear, and yes, there are reticulocytes that we can see there. There's a few more anyway. Here we go, highlighting it. One thing actually it'll highlight here, if you notice, and this is what it is, some weird red blood cells in this case as well. Okay, so this is then, with that finding, you go, is this normal or abnormal? So IDEXX has then gone back, retrospectively, looking at 250,000 CBCs, so I think that's a fair number, and looked at it that reticulocytosis occurred in almost 10% of the time when there was no anemia. So it's like, and maybe we should be paying attention to those retics even if there's no anemia. And that's where there was a paper then put out that describes that. So that's another resource I can give you. But that algorithm is at the back, so that explains that. So what that's talking about there is that if we see reticulocytes, it could be physiologic, so it could be splenic contraction that's going on, or it could be pathologic. So the bottom line is don't ignore them, and need to consider that with the whole diagnostic picture. And in this circumstance, when this case got worked up, it actually found that there was a hemangiosarcoma going on. So if there was no reticulocytes detected in this case, then further diagnostic work probably wouldn't have been done. So it was from noting that and noting that something was happening that worked out there. Now, how can that happen? And that's because there's compensating bleeding occurring. So the amount of red blood cells going into the system is equalised with the amount that's going out. Okay, these are examples that are on that poster for you. So what we can see here is, oh wait a second, the normal here, the abnormal here, okay? And what we're looking at is there's the platelet population, there's the platelet population. So have we got decreased platelets or not? So if we do see this, it's important that we investigate first. So as I said, that we need to be looking at these indices, not just the platelet numbers, okay? So in this circumstance, the numbers are low, but it's important that we look at the numbers versus the volume. This particular breed can have megaplatelets. And with platelets, it's not about the number, it's about the quantity of them all together, working together. So if we've got lots of big platelets, we don't need as many. But if we've got lots of little platelets, we need more. So it's about the ratio of that. The other thing to consider is interpreting it to look at if there's clumps occurring. Okay, so the bottom point is that if you've got low platelets, don't just go thrombocytopenia. Okay, we need to actually investigate if it's true or not. Okay, and that's why we look at the other indices and look at the comparison, and we also look at if there's clumps. And the way we do that is looking at it on our red blood cell dot plot, but we also look at the white blood cell dot plot, and we look at those UBCs, okay, so those orange things. And if we see more of those, and they can even start to reach up this line here, that is indicating that there's clumps of red blood, clumps of platelets that are occurring there. And you'll find the analyzer will actually then put those little asterisks, or it's what's called flagging, next to the platelets when it notices this. And it says, go and have a look. Go and have a look at the smear. So whenever there is any asterisks, and I've got that as well as a resource for you, so the smart flags, and that's in the manual as well. So it basically says, if there's any asterisks, what are the reasons why? But the answer or the solution is make a smear, okay, to go and clarify what's happening. Okay, so with this one here, we can see that this is our normal, this is our abnormal. And we can see there's less dots there. So what we've got is leukopenia going on, and we've got nothing there, okay? So we can see that there's neutropenia going on there, and there's less eosinophils and less basophils there. So we've got generalised happening. And you can see that in what, 1 or 2 seconds, and you can notice that. Now in this circumstance, okay, so this is the opposite. Here's our normal, here's our abnormal. And with our normal, each of these are individual clusters. So we can actually work out the individual populations. But when we start to see populations merging into each other, and where you see these sort of blunt lines between the colour, you know what, that's when the analyzer is getting challenged, and it really can't determine the difference between in the blue population being the lymphocytes or the monocytes here. So it's getting challenged. It's saying my algorithms are saying if the cell sits here on the location, I'm going to call it a lymphocyte. If the cell sits here, I'm going to call it a monocyte. And then the numbers say that. But when you look at the dot plot and you see this colour butting up against each other, I bet you some of those monocytes are not monocytes, and they're actually lymphocytes. And what's going on here is when it's butting up like that, the fluorescence is the RNA. There's lymphocytes that have got more RNA in them because they're being released early from the bone marrow, and they're also being a little bit weird as well. And that's why in this circumstance there's a lymphoid leukemia. And then to confirm that, a blood smear is made. Yes, okay, it's coming in the next slide. This is the case study that goes through this. So this is talking about Sasha, and what I'm just pointing out is those asterisks there, and pointing out that the lymphocytes is high, but also the monocytes are high. But in reality, if we were to count these ourselves, some of those monocytes would be lymphocytes. And then looking at the smear, and the smear is all these weird types of lymphocytes there, and that's what this is a lymphoid leukemia. So from where you guys are at, it's not about you guys making diagnosis, it's about you guys sort of pointing out, gee, that dot plot is not normal. We need to investigate this further, and we don't just look at the numbers and go, bang, okay? We look at those dot plots and we go, okay, this is what could be going on, and this is what's happening, what do we need to do next, and stepping forward from that. Okay, I'd mentioned earlier about cats and dogs are very different for their eosinophils, and if we look at them, cats have got granules that are much more evident than dogs with their eosinophils. They're both there, but cats are they just shine out at you. So this here is the normal for a dog, and an abnormal here in the sense that we've got a lot more of these populations. So you can see the size of the populations have changed here. And then this is cat, okay? So it's important that we're looking at the right dot plot to compare for the right species. And we've programmed the right species into the ProCyte to start off with. So we're looking at normal here, and we're looking at abnormal here. So there's a comparison of that on that chart as well. Okay, so that's just pointing out that there's the chart for you as the go away. And when we're looking at dot plots, all it is I know normal, I need to compare it to abnormal, okay? And the more you get used to it, the more you go, oh, this is going to take 2 seconds, 3 seconds to give me an idea of what's happening. Okay, so here's a case. So this is Blizzard, and just even ignoring the clinical history, even though it's pretty severe, this is the normal here, this is the abnormal here. Looks different. Okay, and I think we can see that, and it's a pretty severe case. So we've got this one here, sudden decreased exercise tolerance, difficult breathing, fever, fluid in the thoracic cavity, consolidated lungs. So that's a pretty sick dog, okay. when we're looking at the dot plot, what we're noticing is, see the individual populations? What we're noticing is this looks like one big clump, okay? And we're looking at these hard lines between the neutrophils to the lymphocytes and the lymphocytes to the monocytes. So when there's hard lines going on there, the analyzer is struggling to say, this is a neutrophil, this is a monocyte, this is a lymphocyte. So it can't work out the cut-off line. It's just saying this is where it is because this is what my programming is. And I guess I was just wanting to point out here is that when I just go back here, whenever we see the neutrophils butting into the lymphocytes and they're in a hard line there, that's because there's more RNA in them. So they're precursor neutrophils. So if they're precursor neutrophils, the one before it is the banned neutrophils. And that's what's really important to know, to the difference between if there's inflammation or if this is a stress leukogram. So banned neutrophils are important to be able to pick up. And that's what the ProCyte can do. So I guess, you know, the banned neutrophils gives you a difference in diagnostic direction. So just the neutrophils, since we're talking about these guys are like the first line of defence. They respond really, really quickly to any kind of infection or inflammation, okay? So they're like your police. While your banned neutrophils are like your rookies, okay? So they're your junior police. So when the neutrophil is developing in the bone marrow, so it sort of breaks down, okay? And they're produced pretty quickly in the bone marrow. But it's the one just before the mature is called the banned neutrophil. And that's what they look like. And they've got more RNA in them, and that's why we can pick them up on the ProCyte. Okay, so going back to Blizzard. And that's where, in the reports, it'll say suspect banned neutrophils. So when we see that colour butting up against each other, that's where it's those banned neutrophils there. It's never going to say banned neutrophils are present. It'll say suspect, okay? Because it's only following the coding of what it's been told. It needs then a human just to confirm that. And that's where there's a discussion down here about there's some abnormal distribution and there's some banned neutrophils present there as well. And on smear, that's where we got the banned neutrophils. And that's what was happening with this guy. There was a septic pleuritis there. Now it's important to trend this. So I started off at the beginning of the talk talking about CBCs. It's important for the objective data to trend it and see the changes over time. And what we can see here with Blizzard, with the change of this one, this is over a 2-week period. So this is when it presented, and then this is only a day later. And then coming down to a week later, and then coming down to 2 weeks later. And you can see, looking at those dot plots alone, you can see changes in those dot plots. We can see treatment started, and look, we're starting to see those populations pull apart already within 24 hours. Now, down here 2 weeks later, it's still not normal, but it's getting there. And that's what VetConnect Plus actually can show that trending. So you can actually see that and line that up, okay? And then you can enlarge it. And this is something that, you know, explaining to a client, like, you know, they don't understand what that is. But if you say, just like I sort of said, you can see that population pulling apart, okay? That's telling you that this is improving. And they'll go, oh, okay, cool, okay? And then, you know, that picture says 1,000 words. So that can help in that. But it also helps with you guys to go, I can see an improvement, even though Blizzard still looks very flat. And that's just to sort of clarify the changes in the cells. So what we've got here is those banned neutrophils coming down to developing more of those mature neutrophils. Okay, this is another case very similar to Duncan. It's very similar to Blizzard. Blizzard was a very severe case, but with Duncan I just wanted to show you a couple of examples of trending in this one. So with Duncan, it's the same kind of thing. Harsh lung sounds, abdominal fluid. He actually had a hemoabdomen as well, so he had it from both ends. And then if we trend the dot plots, okay, so now just when you're looking at it in VetConnect Plus, it has the older data to the right, the newer data to the left. And I know we're used to reading from left to right, okay? So it's just something just to be aware of. So this here is the older data, this is the newer data, okay? This is over a 7-day period, okay? So the numbers sort of are up there. So what we've got here is a decreased population because of the bleed out. Reticular sites take about 3 or 4 days, up to 7 days to respond. So we can start to see coming along here that the reticular sites are starting to respond. And then by 7 days, we're seeing a huge amount of reticulocytes in this circumstance, so these guys here. But you can see that going, oh wow, yeah, it's taking a while to respond. And you can see that on the dot plot. The white blood cells, it's harder to read, so I've got it on the next slide, and I've flipped it around for you, so you go, okay, radio. So in this circumstance here is that's first day, and look, this is American numbers, so it's the 22nd of the 1st, going through to a week later. So on the first day, what we're seeing here compared to even a day later is a depletion of cells, okay? So we're seeing decreased cells that's happening. And then they start to respond. So neutrophils respond quite quickly. And that's where we're seeing like, wow, neutrophils have responded a great deal. And you notice that purple into the blue and pushing up against each other? That is most likely our banned neutrophils, because they've got more RNA in them, so they're pushing up into the lymphocyte population. And you can see more and more of that as the time goes on, and then a week later we're seeing those populations pull apart again. So it's interesting just even looking at this one, because you've got to sort of think about, it's important, this is tracking over a 7-day period the changes that are going on with this case. And how on one day compared to the next day, very different, and that's because cells change really quickly in a CBC, and it gives you a good picture of what's happening and the progression of what's happening in these cases. Okay, I showed you this earlier, is the flags and what to do, and it's evaluate the blood smears. Now I know with you guys being a different practice to most practices, but then there is the option of sending the slide away, the smear away, to our pathologists, and it's called a hematology advantage for the ProCyte. We don't actually put the blood back through the analyzers because we trust the numbers that are coming out the ProCyte. We just look at it for morphology. So you have that option of that profile. Blood smears, I'm not going to go through how to make them because I'm sure you're well versed in that, okay? Reading them, do you guys do that? Yep. Okay, so I guess it's really important with blood smears that you don't take too long because then we make things up. And it's important that we have a systematic way of doing it, okay? So I guess I sort of break down our blood smear as there's 3 areas to look at. We look at the feathered edge for about 10 seconds. So out here, we look at the body. So we're looking at it here, and then we spend about 1 or 2 minutes in the monolayer here. So when we're looking at the feather edge, we're only looking at it at 10 times, so it's just a scan. 10 times for 10 seconds. And all we're looking at it for is big stuff, okay, because they're being dragged along. So that's where we'll be looking for platelet clumps particularly, okay? Microfilariae if you see it, or any kind of large or atypical cells. That's all we're looking at here, and we're just doing a quick scan. Then we move to the body, again 10 seconds, 10 times, okay? It's again a scan. Okay, and all we're looking at is if there's roulet or agglutination. Okay, so roulet being that the cells are just stacked in like coin sort of stacks, versus agglutination, which can indicate autoimmune hemolymph. Okay, big thing that we can differentiate between the two. Okay, the way to do it is a saline test. You put some saline in. If you can't differentiate, the roulet separate out. Agglutination doesn't. Then the next step is to get into the monolayer, and then we go, that's where we go up, okay? So we go up our 40 times or our 100 times and put the oil on and have a look. And we're only looking at there for 1 or 2 minutes. And it's important that when we're looking at it, we do just a rough kind of count, and then we're looking at morphology as well. If this helps, I've got a bit of a guide for you guys too, okay? So we do a bit of a count, and I'm happy to share this slide if people are wanting this, looking at average sort of numbers, okay? And then we go down and look at morphology as well, okay? Now looking at morphology, this really comes to where your skill set is, okay? So for me, I'm a GP vet, I'm not a specialist, okay? So I can work out spherocytes, and I can work out that the spherocytes, you know, they're smaller, they're more dense, okay? While schistocytes and acanthocytes, man, I want a pathologist to look at that, okay? And that's where, you know, there's a very different diagnosis that's going on there. And it could be a life and death decision for that pet. So for the sake of the cost of that test, which is what, the cost, I mean, whatever it means on, but it's $22, whatever it is, then I'd be wanting to do that, okay? Same with inclusion bodies. For me at my level, I would prefer to have a pathologist look at that. But again, that depends on different people's skill set of where we're at there. I guess what I'm just pointing out is you have that backup, okay? Same with looking at your white blood cells, okay? So looking at your white blood cells, there's your neutrophil there, and there's your left shift or your band neutrophil, okay? So I can probably pick that up. When I start to look at some really weird lymphocytes, and you know, you've got some activity that's occurring in the nuclei, you've got some vacuoles, for me, again, I just go, look, pathologist please, okay? But again, depends on your skill set. And then this is just sort of just going through some different examples of how it looks different in different species as well. And even some of the neutrophils, when they've been really, really early release, look how weird some of them do look, okay? And that's where I'm sort of going, oh, you're getting out of my skill set. And that's where I pass it on. But again, that's up to where your skill set is. So as I said, when you're looking at the blood smears, you have that option of that hematology for advantage for the ProCyte, okay? It's different to just the hematology advantage where they run it together, run it again, okay? For the ProCyte is where they're just looking at morphology. Okay, just a couple of summary slides here. ProCyte, you can run it in lots of different species, so it's just to summarise of that. We can also run different fluids in it, so we can do pleural fluid, we can do peritoneal, we can do joint. And then we have the various reports come out just showing granulocytes and agranulocytes, so it doesn't break them up. It can also then do a dot plot. Now this then you'll be passing on with that information of what we need to look at too. There's also, we have internal medicine specialists that are on the phone to consult as well with that information. So I guess when it comes to the in-house analyzer, we're looking at something that has got the capability to do the quality what comes out of a reference lab, but just also knowing what the limitations of it, and that's where your dot plots are helping you. Fresh is best, okay? So when we're running a blood sample, things deteriorate over time in transport. So having the in-house analyzer enables you to run your freshest sample and have your best quality CBC come through. If you do need to send things to the reference laboratory, just some points. Don't put the slides in the fridge. Condensation can affect it, okay? Maybe you might want to send 2 slides away just in case one breaks. You can send the ProCyte data or the dot plots and the results along with your sample if you're doing that ProCyte hematology advantage. Send an unstained slide as well, okay, rather than stained, because we can stain it ourselves and it's actually a different kind of stain as well. And it's important, and I'm sure you guys do this, to have 2 different diff quicks, so one for dirty, one for clean, okay? And make sure you control those vets to sort that out as well, because sometimes they're in such a rush and forget about that. Just walking through, talking about, yeah, the quick turnaround time. So when you have your in-house, the ProCyte can give you a result within 2 minutes, okay? So 15 minutes if we're talking about the catalyst or such like that. I talked about that. And the cost of it, from the ProCyte perspective, you've got bulk reagent. So, and you guys are using it a fair bit, but since it's a bulk pack, the more you use, the cheaper it is per CBC, okay? And then also you have access to the internal medicine consultants and the pathology interpretations as well. I mentioned VetConnect Plus as well. Just to point out, if you're interested, when you're opening it up, there's these little triangles down here. And if you click on those little triangles, it actually opens up an interpretive summary. So you can sort of sound really smart and go, oh, gee, you know, whatever it is, ALT, red blood cells, UPC, whatever it may be. And you go, oh, increases because of this and decreases because of that, okay? So that's there for you as well. So the journey that I've gone through here is, you know, why do we do CBCs? The components of it, I talked about when we're looking at the ProCyte, we're talking about the data, the dots, and then the cells as those components. The technology of it, walked through having a look at those dot plots and going, okay, you know, I'm hoping that I've demystified that for you as well, and just some aspects of blood smears and if we're using the reference lab. Any questions? Comments?
Sending away the slides, I remember in general practice, I rang up once to find out if I send more than one slide away, if we get charged per slide. Is that correct?
No.
Because I rang up items once. And
Okay.
the amount of slides you send away, you get charged for everything.
Yeah, not for a CBC, okay? Yeah, not at all. If it was cytology and that circumstance, but when it comes to lymphocytes, it's all one price there, but if it's, and there's different changes of different areas and things like that, but yeah, not when it comes to CBC, so good question, but no, that's not the case. So yeah, hopefully it's a misinterpretation. Okay. So I guess I'm hoping that you've now sort of look at the ProCyte and go, there is so much more in it. It can do the F18 stuff and break the speed of sound. And you'd like, my husband likes planes, so that's where it's come from. Rather than, you know, the little putt-putt Cessna. Thanks, guys.